All right, so we're going to start our fireside chat with Stacy Cummings, Program Executive Officer for the Defense Healthcare Management Systems. All right, she began her career at the Department of Navy prior to DoD and held senior executive positions at 2 operating administrations within the Department of Transportation. All right, thank you all very much. Sorry to have to quiet you down. All right, I'm just going to start by asking you to tell us a little bit about what you do, what your overall focus is at DHMS and with Genesis, of course.
Sure, thank you. So as the Program Executive Officer, I am the senior accountable official overseeing 3 program offices on behalf of the Department of Defense. And the 3 offices have 3 different functions. The first office I'll talk about is the one that we'll probably spend the most time today talking about, which is the modernization program. We're deploying a modern, secure, connected electronic health record called Mhs Genesis. Second program office is actually taking this modernization program and then configuring it for operational medicine. So as you might imagine, in the Department of Defense, we have garrison, we call garrison hospitals, which operate as clinics and hospitals similar to as you would see in commercial. But we also have a forward deployed mission, and that's different than you might find in commercial. We deploy healthcare professionals and provide healthcare aboard ships, aboard hospital ships, in theater, and in transit between theater and then coming back to a garrison hospital. So there are some unique workflows associated with that and some very unique technology associated with that in a low or no communications environment. So that's the second program office. My third program office is actually an interagency program office completely focused on data sharing and interoperability between the DoD and the VA. It's called the IPO, the Interagency Program Office, and in the past they've really been focused on standards, those underlying things that are necessary to ensure that we can actually understand the data that we're sharing and that we can move forward in our interoperability goals. Now with the VA's recent decision last year, they decided that they were going to adopt the same electronic health record as the DoD, Mhs Genesis, and so we've expanded the role of that program office really to look at how do we best align ourselves to deploy and take advantage of a single domain electronic health record that really puts the service member, the transitioning service member to veteran, at the center for the first time. So we're not talking about interoperability anymore, we're talking about integration. And again, putting that veteran center, and we can talk more about that as we continue with the fireside chat.
Yeah, all right, wonderful. So if you can give a broad description of what Mhs Genesis is, what its plan is, and the testing you've done so far at the 3 sites out west.
Sure. So we've actually deployed Mhs Genesis to our 4 pilot sites in the Pacific Northwest. Mhs Genesis is an integrated inpatient, outpatient electronic health record that brings together medical and dental really for the first time. So in the past, we've had multiple electronic health records on the medical side, and we've been operating on paper from dental. So really bringing together that medical and dental, that's groundbreaking. That's really, we're breaking new ground. We're doing something that's new and innovative there that we really haven't done before. The other thing we're doing is bringing inpatient and outpatient together and really creating that seamless environment within our hospitals where a patient, whether they come in for the emergency department, they're inpatient, moving to outpatient, all of their data is readily available, and all of our workflows are supporting that transition of care throughout the military health system. So Mhs Genesis really brings together 2 market-leading commercial off-the-shelf tools. On the medical side, it's Cerner Millennium. On the dental side, it's Dentrix Enterprise by Henry Schein. And again, as I said, bringing those 2 things together for the very first time. Now, there are some DoD requirements that are a little different than commercial. And in order to meet some of those requirements, I'm going to specifically talk about things like readiness. You don't manage readiness of an individual or of a unit in commercial, and so we really had to look at our legacy and unique DoD tools to meet those requirements. Another requirement is identity. So when you go into a commercial hospital, your identity is kind of associated with who you are and what your insurance is, and those things come together to create the record. In the Department of Defense, we need to know who a person is, whether they check into a DoD hospital on the West Coast, a DoD hospital on the East Coast, a commercial hospital, wherever they go, we need to know who they are. And so we manage identity just a little bit differently than they do in commercial. And so these are Mhs Genesis really not simply the deployment of a COTS tool, it's the deployment of two market-leading commercial EMR and dental record, along with the interfaces to our DoD unique requirements. And that is what Mhs Genesis is. So you asked me about where we are. We've deployed to the 4 sites, and between February and October, we deployed to Fairchild, followed by Oak Harbor, Bremerton, and Madigan. We went from smallest to biggest. And the reason that's important to know is that we wanted to gain experience and lessons learned and apply them to each of our larger implementations. But the other thing that's important is that we didn't have the opportunity to truly test the breadth of our capability until we got to Madigan in October. And so I know that you've seen in the news recently, we had an independent test report that was completed. The actual analysis was completed in 2017, and it completed around the November-December timeframe. Since then, we took all the feedback that we got. We actually got an upfront copy. We didn't wait until the test report was signed. We got all of that information. We got a ton of information from our users. And we said, we worked with the test community, and we said, well, we've done testing at 3 sites. We decided together we needed to push off testing at Madigan because we knew that we had lessons learned from our first implementations that we wanted to apply. But again, we wanted to wait until we got that Madigan deployment completed so that we would understand the full breadth and that we weren't making decisions for a single site or a single service, because we have 3 services and 4 sites. And frankly, we have hundreds of sites across the world that we need to create a solution that works for all of them. A few minutes ago, Colonel Scott talked a little bit about the idea of in each of the MTFs doing things just slightly differently. Vice Admiral Bono, who's the director of DHA, likes to say that we have 18 different ways to order a CBC. So what we needed to understand was the full breadth of our capability in the correct operational environment so that we would make the changes based on what's best for the enterprise, not for a single site. So we got all this feedback, we collected all this feedback, and in January, we kicked off what we called the Stabilization and Adoption Plan. Now, the opportunity to employ lessons learned was always within our program schedule. But when we looked at our test feedback and we looked at our user feedback, we realized that our decision-making on the government side, our decision-making was separated by 3,000 miles, and we really needed to bring those closer together. So we took a team of government and Leidos Partnership for Defense Health personnel, people, teammates, and we sent them out to the Pacific Northwest to actually sit next to the users, to truly understand what is it that you're struggling with in the adoption of this workflow within the Mhs Genesis tool. A lot of times we found that it was around training, and this is something that we've admitted, we've shared openly, that our training strategy was too focused on technology and not enough focused on the adoption of workflows. So that was key. You saw it in the test report, we saw it, and it's something that we tackled when we went to the stabilization and adoption.
The help tickets.
So the Helpdesk Tickets. Let's talk a little bit about those. So I'll divert to that just a little. We've been receiving Helpdesk tickets since our very first deployment at Fairchild back in February. Now, Helpdesk tickets can be anything from I need to add a new user to I really wish that the dental solution allowed me to do surgery in both dental and medical at the same time. Mm-hmm. Everything in between. And so there were things in there that people identified as patient safety, boom, they go to the top of the list. There are things in there that were identified as this user doesn't have the right access, boom, that goes to the top of the list. And then there were some things that were future enhancements, or maybe they were already in Cerner's plan in the upgrade that we knew that we would be getting later. Those move to the bottom of the list. We have taken care of, closed, combined, brought together a vast majority of our Helpdesk tickets. And I think the last metric that I heard was about 88% of our tickets. At our height, we did have a backlog of tickets, and you've heard the number of 7,000. And at the height of our implementation, we had about 7,000 tickets that we were managing. Again, a large portion of those purposefully put to the side to say those are enhancements and they'd require decision-making from the enterprise. And some of them are things, yes, we need to make changes to them. So again, 88% of them are either in a forward-looking or are closed. And we have gone from about 40 days to respond to a help desk ticket down to 12. And so what that tells me, along with some of the other, and I'll share some metrics with you about how our sites are adopting, is that we've really turned a corner. And the test report that was done in 2017 was great input to allow us to turn that corner. And so I'm going to pull out my notes, and I'm going to share my metrics with you. But this is a comparison between November of last year, which is around when the test report was done, to March. So in the month of March, we had 120,000 clinic visits documented and managed in Mhs Genesis at our 4 sites. That's a 20% increase from November to March. A 22% increase in the use of barcoding, which is a very important patient safety capability. 148,000 prescriptions, which is up by 78%. That has a lot to do with some policy decisions that were made in the military health system. So really the demand has gone up. And as Colonel Place mentioned to me on Friday, it went up without a significant increase in the wait time at Madigan. And so we're seeing that as our users are being able to adopt and really learn how to use the system, they're able to increase the amount of care that they can give, which is demonstrated in the metrics I just talked about. Additionally, nurse time in the EHR has gone down by 25% between November and March. And just since January, between January and March, 1,300 duplicate orders have been avoided. That is money saved. It's also tests that patients didn't have to take or spend time away from their family in order to do. So when I say that I see us turning a corner, I really think that the stabilization and adoption period, as well as taking an upgrade to the Cerner Millennium baseline, has really got us moving in the right direction. I'm very optimistic. I will tell you that Vice Admiral Bono, who is the director of DHA, she represents our customer. She's very optimistic that we're really heading in the right direction. And as Colonel Place mentioned, that it's constant improvement from a clinical delivery of care perspective that our users are looking for, and we're seeing that shift and that upturn. So again, there are challenges we still need to overcome. There are some things that our users and the services, Surgeons General, have asked us to focus on throughout the rest of this year before we begin deploying to our next sites. But they're all manageable, and they're all things that we knew we needed to work on, again, because of the tests, because of our user input. And I'd really like to highlight the really close relationship that we have with our user representative, which is the Defense Health Agency. And so in the past, I mentioned that our decision-making around what will the enterprise solution be, our decision-making wasn't quick enough from a functional perspective. And so one of the things we did is we looked at our governance structure, and we realized that while governance worked when we were trying to identify standard workflows, when you've deployed and you really have people on the ground using the system, you don't manage that through governance, you manage it through management. And so the Defense Health Agency has put in place a management structure so that we're making tactical decisions that support the users on the ground, and that's how we've gotten to this 12-day turnaround for a help desk ticket versus 40 days. It's really around the decision-making, in the DoD, we call it in the OODA loop, but it's around that decision-making that doesn't get made by the Leidos partnership. It doesn't get made by the acquisition program office. It really gets made by the user. And now we have a structure in place to support the user and make sure we're able to do that as quickly as possible, but with what we like to call deliberate haste, because we are making decisions for the whole enterprise, which means that it can't be a solution for one site in the Pacific Northwest. Balboa and San Antonio and Landstuhl in Germany, they all have to be able to use these standard enterprise workflows as well as the technology to support the delivery of care.
So does this change at all the 2022 timeline, and what does it mean for the VA and the Coast Guard, their decision? Does it alter that timeline at all?
So we had always looked at having a time period between our IOC sites and our future deployment sites so that we could capture lessons learned, do our testing, as well as make sure that our deployment strategy, our training strategy are going to work for us long term. And so we had always planned in fiscal year 19 that would be the first time that we would deploy to our future sites. One of the lessons learned that's really going to drive our schedule that we got out of our IOC sites is the infrastructure. So the local area network infrastructure, the connectivity of medical devices, the connectivity of printers, all of those things are critically important to have a successful rollout of a new EHR. And frankly, in our IOC sites, we didn't leave enough time for the stability of the network before we deployed the EHR. That was a mistake. And so we're giving ourselves a little extra time before our first deployment in 2019 to make sure that we get the infrastructure right. We are actually looking for about 6 months of stability with the network prior to deploying the electronic health record. A lot of the reason we need that 6 months is around verification of lab equipment, of devices, of really making sure that it's stable and that the local site infrastructure leads are able to manage it before we come in with this big transformational electronic health record deployment that is really just going to transform the way you do business. You don't want to be doing those two things at the same time. We are working with the Defense Health Agency who's deploying that infrastructure to make sure that it's there in advance. We currently believe we can still get there in 2022. We're working together to make sure that we have a good plan. We don't want to rush in if the infrastructure isn't ready, but we're putting that plan together, and I have confidence that we will work together to have the right solution. And as of right now, we're on track for 2022. If that changes, we will absolutely be transparent about, about any changes that we need to make. But my goal is 2022. The Defense Health Agency's goal is 2022. Pretty sure the Leidos Partnership's goal is 2022, and that's what we're working towards.
All right. Awesome. Thanks. Do we have any time for Q&A? All right. Yeah. Perfect.
I know, you have sandwiches. You can't ask questions with sandwiches in your mouth.
That's
so.
true. Anyone have a question? We have Matt's walking around with the mic. No questions. You answered everyone's questions.
Well,
all right.
I guess if I get to say something in I mean, I've talked the whole time. I didn't even let you ask me any questions, did I? But one thing that is really important to us is this is a unique program office. It's a unique program. It's a unique program executive office, and our relationship with our customer is very strong. There is a lot of interest in the Mhs Genesis deployment with the entire country because it impacts not just our service members, veterans and families. It impacts the Veterans Administration, the transition of care, and now bringing in the Coast Guard is another great story narrative because of the closeness of the Coast Guard and the military services. They come into the military the same way any Army, Marine Corps would come in, and they go to the Veterans Administration the same way. So we're really excited about that. But the deployment of Mhs Genesis is truly functionally led and frontline driven, meaning that all of the feedback that we've gotten from our sites is critical, it's important, and we've asked for it. We've really told the sites, and I personally went to visit every site before they went live and after they went live for the sole purpose of letting them know that it is their job. We are counting on them because they are actually the ones that are going to determine what is the baseline software configuration, what are the workflows, and how are we really going to transform the delivery of healthcare for the entire military health system, not just for their sites in the Pacific Northwest. And so we asked for their feedback, we got it, and I think as you may have heard our functional community said, and we got a lot more than we thought we were going to get. We got a lot of feedback, and it took us a little while to be able to put that decision-making construct in place so that we were, again, making the right decisions for the enterprise. But at its base, we are deploying 2 leading commercial off-the-shelf electronic health and electronic or medical and dental records to, for the first time, create for the military health system an integrated inpatient and outpatient electronic health record, bringing together medical and dental that is going to transform the way we deliver healthcare and as the Department of Veterans Affairs begins their modernization journey, for the first time put that service member, that transitioning service member and the veteran at the center, so that they don't have to, like my husband when he retired from the Marine Corps, spend 2 weekends at Kinko's making copies of records. We are going to deliver that seamless transition, not just for people who have to do it because they want to get into the Veterans Administration, into the database, but because they truly need their care transitioned. They have serious medical issues, that they're wounded warriors. We every day when people at PEO DHMS come to work, we know that what we're doing is directly impacting service members, veterans, and their families. It's the best mission, and it's an awesome place to work. So, hey, we're hiring. Anybody wants to come work? We have a great time.
Thank you. Thank you so much.
Oh, sure.
Oh, okay.
I thought I talked long enough so you couldn't ask a question.
Well, I hurried up and chewed my sandwich and got it down so I could give me time to think also. So great presentation, Stacy. Really appreciate it. I'm Quintus Brown with Government CIO. I have just a couple of questions. As an engineer, when you said you went from 40 days down to 12, I'm thinking, all right, how do we get to 2? So I'm curious, is there a plan to try to reduce the turnaround time on trouble tickets from 12 to some other goal first? And then secondly, probably more importantly, what's the real downstream effect beyond the users of the system, probably all the way to the patient, of being able to reduce that trouble ticket turnaround time?
So actually, you are going to get to hear from the chief engineer. Since you're an engineer, you might want to have some engineering speak. She's on the future panel. But as I said earlier, we don't want to stop people from putting in tickets that are long-term. So we don't want to say, well, we're going to drive our ticket time down so much that we don't leave room for the innovative users to come and say, hey, you know what, I'd really love it if Cerner Millennium would do this, and then we can take it back to Cerner and say, hey, all of your customers would benefit from this. So I don't want anybody to think that our goal is to drive our tickets to 0, because if we drive it to 0, we're not getting any innovative ideas that are going to help us as we move forward and take advantage of really having a commercial system. But to your point about how do we drive those tickets even to an even shorter, a shorter turnaround time, that's all about getting the right people trained to be able to make the right decisions from a functional perspective that are able to make those enterprise decisions. And so when I talked about creating that management structure in the Defense Health Agency, what we've done is we've laid out that structure when we have some people in it right in those positions. Now we need to get them trained and experienced so that when a user comes up and says, hey, you know what, I think it would be better if I could see this in this view instead of in this view, somebody from the functional side needs to go and say, yeah, you know what, that's a good idea, and then send it off to make that change. Or to say, no, that's a bad idea, and here's why, because here's how the system is supposed to work. It's working as intended. Until we get really that cadre of trained functional providers, then we're having to take our time and make sure that we're making the right decisions. So how do we drive that lower? We continue to train and get more experience. As in any enterprise deployment, until we get 25–30% of the MHS trained, we're really not going to have that cadre of people to send to the next site to really get people to understand why we configured the system the way we configured it to the benefit of patients, to the benefit of our users, to the benefit of standardization. And so yeah, our goal is to drive it down, but I don't want anyone to think we're trying to drive out that feedback, because that feedback's critically important. So we want to drive it down as much as practical, and I think I'll leave it up to you engineers to talk about what practical means. But that's our continuous improvement, exactly. Right. Yeah, exactly. Sure. I answered all your questions? We're good? Okay, I'm getting the hook. So thank you. Thank you all so much.
Thank you all so much. Thank you, Stacy.